What role do markers play in active surveillance? Well, you know, thanks to several people in this room, active surveillance is on the rise. There were some randomized trials comparing surgery and various treatments to surveillance or just watchful waiting that showed it was relatively safe, at least for 10 years. In many of the case series here, and certainly you can't mention active surveillance without mentioning Lori Klotz, you can see how the uptake of active surveillance has gone in the last few years, but we're not doing it perfectly. Here's some data from the PROTECT trial, which shows that even after assignment to active monitoring, as it was referred to, you know, within about 5 years, 40% of the patients tumbled to aggressive therapy of some kind. And now if you could read the fine print here, even though at 10 years there really was no difference in prostate cancer mortality between the patients undergoing surveillance, surgery, or radiation, numerically there were 33 patients in the active surveillance group who had metastatic disease versus only 13 and 16 in the two other groups. So we can do a better job selecting patients for active surveillance. We'd like to avoid excess metastases, and we'd like to really select the patients who will never go on to aggressive therapy. So that brings us back to the NCCN guidelines and the available tests to risk stratify patients at the time of diagnosis. And you can see them all listed here and all the details of it. And the important summary is that each of these tests, as indicated above, provides information that is independent of the clinical variables that go into the NCCN classification and/or the CAPRA risk score. Having said that, NCCN is very, very narrow in the groups of patients whom you should consider ordering some of these tests on tumors, and it's basically restricted to your low and your favorable risk intermediate patients. And you could read the details there. Very recently released was a ASCO and I believe SUO collaboration to look at molecular biomarkers in localized prostate cancer. They reviewed 85 studies. The first question, are there molecular biomarkers to identify patients with prostate cancer most likely to benefit from active surveillance? Routine ordering of molecular biomarkers is not recommended. Evidence-based, intermediate strength, moderate. Are there molecular biomarkers to diagnose clinically significant prostate cancer? Not recommended, moderate, intermediate. And I'm going to mention a little bit, I probably shouldn't, what are the comparative strengths and weaknesses of genomics versus MRI. We're going to have a lot of MRI discussion tomorrow. These tests may provide information independent of routine clinical parameters and independent of one another. And here's the table from their paper, again, comparing the most popular tissue-based markers. You can see their list price, and obviously that has nothing to do with reimbursement or what the patient actually pays. I just wanted to make this point, and I know Kareem is going to be emphasizing this later. Patients with BRCA2, this panel felt, and I think I agree with it, there is still insufficient evidence in the favorable risk setting to make strong recommendations regarding the impact of these mutations on active surveillance eligibility. And we'll probably have a lot more conversation on that down the road. Now, this is a paper from the Michigan collaboration on the use of gene expression classifiers in patients with prostate cancer. You can see of all those practices in Michigan, there are wide variations. Some practices use it almost never. Some practices use it quite a lot. And you can see the size of the practice. Moreover, you could see that there are different tests, Prolaris, Oncotype, and Decipher, used in different practices. You can see how the tests on average read out differently in patients with favorable risk, unfavorable risk, et cetera. You can see that there's a certain amount of variability. The crucial things from this paper, I think, are first on the table that, yes, knowledge of the results of these does change behavior. So if your test was below the threshold, your odds ratio for surveillance went up a lot. If it was above the threshold, it went down. And the academicians, by and large, put more patients on active surveillance than the others. And the other thing to notice is that in the favorable risk subgroup, these data indicate that one additional patient would undergo active surveillance instead of surgery or radiation for every 9 patients tested. So that's sort of the number needed to test to change something. The converse is that one additional patient would undergo primary therapy rather than active surveillance for every 26 patients tested. And that's only in the favorable risk subgroup. Now, we're going to talk about MRI a lot tomorrow, but I thought I'd give it a little bit of a shot here. These are some data from UCSF looking at patients who progressed on active surveillance and had an MRI and had, in this case, the Oncotype test. This is very surprising to me because our MRI colleagues will tell us that there are differences between PIRADS 1 and 2, 3, 4, and 5, but at least using the Oncotype test, there's very, very little difference in the Oncotype, the mean Oncotype reading of the patients who had MRI detected lesions on active surveillance. Yeah, we don't have to go over that. And again, this is some work from Lori Klotz. Again, I'm just sort of setting the tables tomorrow to kind of talk about MRI. The difference in systematic biopsy versus MRI targeted biopsy, there was no change in the probability of finding higher Gleason scores, whether the patient under surveillance had either a systematic or an MRI guided biopsy. This is another thing that surprised me, a paper from the group at the University of Michigan. They looked at some prostates that had only Gleason grade 1 and other prostates that had a Gleason grade 1 focus, but there were also other foci of higher grade Gleason scores. And they looked at these genetic classifiers in the index Gleason grade 1 tumor. And you can see that if you were in this low Gleason tumor only prostate versus bad prostate over here, there really wasn't a lot of differences in the genetic classifier scores for Prolaris, Decipher, or Oncotype. So I think the concept that a needle biopsy of a low-grade focus in a prostate that may harbor more aggressive disease is telling you about the entire prostate is a little bit suspect. And that's, I guess maybe they said it more clearly here. These findings demonstrate that prognostic RNA expression assays performed on low-grade prostate cancer tissue may not provide meaningful information on the presence of coexisting and unsampled aggressive disease. This is a single patient, and I got this from Sinoj Poonen at a meeting we were at a few months ago. This is a patient who had 2 foci of Gleason 6, and he entered onto active surveillance. And you can see how the 3 scores read out on each of those 2 foci of Gleason 6. This patient then, about 9 months later, had a confirmatory biopsy, and he had tons of different foci of cancer discovered on his follow-up biopsy. And you can see each of those foci was again scored by these 3 different tests, and you can see how you got totally different readouts in terms of risk, high, intermediate, or low, on the basis of which test you used. And that's kind of like this study from European Urology a number of years ago that looked at radical prostatectomy specimens. And you know, many of these prostates had more than 1 tumor in it. But here's an example on Oncotype. This particular tumor focus was considered high risk. It was considered very favorable risk by Prolaris, and it was considered about average by Decipher. So there's a lot of variability in how these tests read out for an individual cancer. Again, this is from Sanoge. When you measure all of these markers on all of the different tumor foci, the genomic clinical risk level changes in 10 to 15% of the cases, depending upon which core you use and which test you use on a given core. So Klaus isn't here this year. You know, Klaus has a way of saying things. Prostate cancer genomic testing is flawed. 3 reasons why. Sampling issue, abstract data, and you have to read these because these are very Klausian, describing how prostate cancer is like buying a new refrigerator. I hope you're going to circulate these slides to everybody. What is the way forward? This is a proposed study, or actually I think the study is ongoing in Michigan. It's referred to as the G-Major randomized controlled trial. So these are patients who are eligible for active surveillance. They get randomized, a genomic test not performed or a genomic test is performed, and it could be any one of the 3 tests. These patients are followed, and a decision is made for treatment or surveillance on both arms, and then a comparison will be made down the road in the setting of grade reclassification, indolent pathology of prostatectomy, biochemical recurrence, and overall quality of life. I think this is a very, very helpful test to go us forward. Now, I know I already quoted Klaus Rarborn, but then there was this other guy, William Osler. Medicine is a science of uncertainty and an art of probability. I think where we are right now, clinical criteria are very useful. Let's not ever forget the use of the clinical criteria to assess the cancer. MRI or other image-guided biopsy may add some additional certainty to the decision for surveillance, but it's definitely not perfect. Gene expression classifiers add some further certainty to the decision for surveillance. And there are probably tons of other markers that we should be looking at to figure out who best is a candidate for active surveillance. So thanks very, very much.